Welcome all of you. Today's session of discussion is very, very important and relevant for all of us because that's probably one of the biggest challenge we all experience in our communication with the patient and their family member, and that's about breaking bad news. I have seen even very seasoned clinicians experiencing some amount of anxiety and tension when they have to go and break a bad news, especially when once it is something that probably they had not thought of or they had not discussed with the patient, or it was something unanticipated and it happens. So it's really a very challenging thing. So we are trying to going to understand what is the protocol of breaking bad news and what exactly we mean by bad news. If I may ask all of you to give your thoughts, what do you think? What do we mean by bad news?
Information pertaining to mortality or morbidity?
I think that's a very broad and very, correct information or definition, I can say. Any other understanding?
Anything which is unexpected.
Anything which is unexpected, that's bad news. Absolutely. Any other version?
That the patient may not improve.
Yes, when the prognosis is poor or there's a possibility of deterioration or irreversible kind of. Yes, please, go ahead.
When the outcome is negative.
When the outcome is negative, absolutely.
Unpleasant news.
Unpleasant
news. Unpleasant.
So if I may ask you in terms of the diseases that you think would come under this category, what would they be?
Myocardial infarction, heart attack, CVA, cerebrovascular accident,
CVA,
oncocarcinoma, cancers.
Cancer patient, absolutely. Cancer.
Any specialty has its own negative outcomes. I mean, endophthalmitis in my specialty,
Yes.
retinal detachment, or any complication, lens drops.
So it's not just endophthalmitis. I have seen, parents, or especially the mothers, literally crying and fainting when they get to know that their child is, high myopic or is hypermetropic and or is amblyopic. I have seen this happening. In my own clinic, I still remember there was a medical student who was brought by his parents. It was a clear-cut case of OCD, but parents probably were in denial, and they came with the request that probably he's very stressed out and he's not able to cope up with the pressure. So that's why he's behaving in a very different manner. And please counsel him, and he has exams and he should be preparing for the exams. And other than that, he's actually doing all other weird things. So helping them understand that this is a proper disorder. And right now, your priority should not be exams or continuation of education, but it should be, helping him, deal with this and also manage this condition was a very huge challenge to help them understand. And I'm sure each one of you in your own specialty must be experiencing similar kind of a situation. I saw some of the messages sent by Dr. Sheetal. She says, disfiguring disease. Yes, patients who have to undergo any kind of amputation. I mean, it's a huge, huge change in the lifestyle. That's a real, bad news for them. So bad news is not just death or any major illness, even small health conditions. I think if you ask me my experience, I'm talking about say around 20 years ago, when my kids were very, very young. I had, cough and pain in my lower lobes. So my husband took me to one of his friends who's a physician. He examined me and he asked me to get the X-ray done. X-ray was done. There was some shadow in the lower lobes. He said, it looks like, tuberculosis, but let's hope that it is not. Let's start with simple antibiotics. And in case if the shadow does not subside, then we'll have to investigate you for tuberculosis. So for those 2, 3 days or 5 days till I was taking the antibiotic, my whole world came upside down. My kids were young. I was supposed to be, looking after their education, their food, their other, requirements. For me, 110 questions came to my mind. Who will look after my children? Who will feed them? Can I hug them? Can they sleep with me? How will I teach them? And can we share meals together? And fortunately, after like 5 days, X-rays were okay. My condition was fine. I mean, there was nothing. So tuberculosis, which is such a a common illness now, and we know there's 100% recovery. People are fine after the treatment. Imagine, I mean, me knowing it had so much of challenge to accept it. I'm sure. I mean, you all must have seen happening this in your friends and families, experience. So, anybody has any experience where you would like to share, where you did the breaking of bad news, or you were receiver of the bad news, and how it affected you? If you would like to share your experience. Yes, sir. Yeah.
I'm a vitreoretinal surgeon, ma'am. I'm a retina specialist.
Ji.
This is about a 26 years old girl
Mhm.
who lost her one eye in retinal detachment
Mhm.
somewhere else. And in other eye also she developed retinal detachment.
Mhm.
That was operated by me.
Mhm.
And she developed, she was successfully, the retina was successfully reattached, and she regained a vision of 6/6.
Okay.
But I had to prescribe him a glass of +1.
Hmm.
When she came to know about that she will have to wear a +1 glass, she fainted in my clinic.
Oh my goodness.
So, and she recovered from retinal detachment. If you know, it's one of the most serious disease of
Most
retina.
serious. Absolutely.
So you don't know what are the expectations of the patients.
Absolutely. Absolutely.
So
Yeah, and sometimes you think that it's such a small thing. What is there
yeah,
to
I mean,
react?
for a surgeon,
Yeah,
who knows retinal detachment,
absolutely.
people who know retinal detachment, they will be very happy the retina is attached, the patient is able to see.
Yeah,
But patient का expectation क्या है? वो
we don't
अब
know.
जैसे हम लोगों के यहाँ बहुत अच्छी सर्जरी आपने कर दी, अब तो आप सब खुजली हो रही है, and that
Ah.
खुजली will spoil the whole of your effort.
Absolutely. खुजली हो रही है, पानी आ रहा है. I mean, and specs पहननी पड़ेगी, तो ये बहुत बड़ा एक उनके लिए एक हो जाता है. I completely.
To some extent, these expectations have been given by the doctors themselves in the corporate system.
Yeah, absolutely.
Media,
Absolutely. Yeah.
pricing, marketing.
I completely agree. And also sometimes we think that we go with the wishful thinking that nothing will go wrong. So we sometimes don't, prepare them actually, So at the end, sometimes we end up into difficult situations. So I think we'll do a small role play here. And in the role play, actually, I would prefer to ask people who are not doctors to play the role of a doctor. And people who are doctors, let them be patients and patient's family member. So we'll take a situation that your patient is a young man or woman with pancreatic cancer, and you have to break this bad news. So why I'm asking for a role reversal is that sometimes we think that it's something very simple, it's something it can be done very easily. But in reality, actually, we all know that it's a very difficult communication to make. So, and when we reverse the role, we get to see the patient side or the family side and also the clinician side. Is that okay if we take this kind of a format? Is everybody okay with that? Okay. Any questions or anything that you wish to ask? So I'll be sending you all in the breakout room. You are total 9 of you. So I'll be making 3 breakout rooms. So in each breakout room, you will be 3 in number. Let one person play. In case if there are 2 doctors, then definitely you will have to take the role of a person who will be breaking the news. So just try to get into that role. Try to be as real as possible, and even try to create the feelings that you would have actually if you were in that situation. So I'm making 3 breakout rooms. I'm going to send 3 of you in each. Any doubts about the any questions about the situation? Is it clear to all? It's a young patient of pancreatic cancer, and you are going to break the bad news to the patient. So I'm making 3 breakout rooms. And we'll just spend 5 minutes in the role play. Padma Pamni, I would request you to join one of the groups so that you get to feel the situation. So, Dr. Hamid, which group are you in? So first of all, I think all three groups were really, practicing very well in a very proper manner. I entered all three groups and observed it. So that was a good observation. So if I may ask the persons who were playing the role of the doctor, how did it feel to be there? Somebody's device is on. Can you please mute your device? Thank you. Thank you. Yeah. So,
It is
yeah.
difficult.
So one by one. I think, okay, Dr. Seema says it is difficult.
It is difficult. You don't know like what to say exactly, whether to really tell the truth at this moment or not. Like how the attendant will react or how the patient will react. It is quite difficult. I mean, you really have to go around like that. You cannot come to the main point directly.
So you were finding it difficult to give the exact information in a clear manner.
Yes.
So there was a little bit of beating around the bush that you are saying.
Yes.
Yeah. Okay.
Fortunately for me, my patient was a very nice gentleman.
So he didn't have any questions, or he was okay with the.
He was so calm.
Yeah, same here. I think Hamid was just a fantastic patient. He knew everything, and he was very calm and composed, and he said yes to everything. So that's lovely. I wish we had patients like that.
मोहन जी बता रही है और वो मेरी जो पेशेंट है वो सुन रही है वो जो he is just listening.
Okay. So Mr. Vijay, what was your experience?
Yeah, I mean, definitely I felt it is difficult to convey that bad news. But, as Sheetal ma'am said, like Dr. Hamid was very, nice patient. Though, he has shown some kind of anxiety, I was trying to control his anxiety before giving the news. But it was good experience actually. So how do we convey the bad news to the people? Only thing is, when the people come with requests saying that don't tell it to my parents, don't tell it to the patient, right? I don't know how to react to that, right? I mean, should we tell them or should we not tell them? Considering all the ethics and all, probably I need some guidance there.
So what do others say if the patient says that don't tell my family, or sometimes the family member says, please don't tell the patient that you have this disease? So how should we handle it?
Ma'am, that's one thing. Like the social fabric of our country is such that we're very caring people and we have a lot of attendants. So in that way, we wouldn't be wrong in saying, okay, I'm telling the caregiver and it's okay. But later on, I don't know if this information is not given and how it stands in the court of law. So unfortunately, we are weighing this, empathy versus being right. So I don't know. I don't know. I think we, as from a clinical or a proper ethical standpoint also, we have to have a way in which we have to tell the patient. This is my understanding actually.
Actually, we'll discuss it definitely. How about
it is definitely difficult.
Yes.
It is definitely difficult.
Yes,
it's quite a dilemma. But yes, definitely straightforward. We cannot convey this through to the patient.
Okay, I agree.
We have to kind of sensitize the patient over a period. Yes, caregiver can be given all the information. Caregiver can be information, all the right information also, and especially mixed with hope. It has to be mixed with hope. It has to be given with mixed always. That I have learned during my practice. So whenever we disclose some bad news, in the same, maybe even in the first sentence, I generally start with the positive thing, with the hope.
Yeah. So what do others say? Yes,
Dr. Praveen has said a very, very, very nice point that we are no one to say negative. I mean, even with so much of advanced medical thing, हम लोगों में, I mean, how can we pass a judgment that this person will not live? I think we should always give some hope, even in a very very, very severe. I mean, otherwise, whatever psychological positives the person has, he will lose everything.
That
आप
hope
उससे
is
पहली
lost.
बार में ये कह सकते हैं भाई तुम नहीं जी पाओगे 3 महीने से ज्यादा, तो आपने उसके वो 3 महीने भी खराब कर दिए.
Absolutely.
And we have no right to.
Yeah.
Earlier, I also used to do these things. I used to be very rash with serious diseases, but now I have learned. I mean, I am nobody to say that you are going to be blind.
Very good. I think I agree with you. Very good. Any other thought?
But
Yeah.
at the same time,
Yeah.
somebody responsible in the family should be told about it, and it should be noted in your record that you have informed this person with about the prognosis.
So what do others say? Any other additional point, if anybody has to add to what we are discussing?
Ma'am, what is the legal standpoint on this? What did Mr. Mohan have to say about this?
So we have a legal expert with
Sorry,
us.
my question was.
Yeah.
Yeah, so I thought, what is the stand in the sense that yes, for the purpose, if I don't tell the patient that he is, dying, let us say, how I would defend it is that I would say, okay, unfortunately, if this news would be more counterproductive and it would cause more, mental harm.
Yeah, damage.
So this is what I may use.
Yeah.
But if it is, if somebody asks me that no, this person is completely, is able to consent, is able to make his own decisions, why didn't you tell him? I don't know. I mean, it's very, very gray.
So, Mr. Mohan, do you have any point to add here? That will be nice if you add your,
Ma'am, before I say anything, one must remember, medical practitioners must remember to document everything, even if this decision to make this judgment is also confusing. That must also be documented.
Yeah.
The psychological impact may worsen the disease. We must have that also in my mind. We must keep that in mind. And the treating doctor definitely has that discretionary power with him. I would always, in a very dicey situation, whether to do it, whether not to do it, it's always better to refer the patient or the patient's parties to a psychologist or a psychiatrist, then you actually move that, you're actually showing that you're trying to do the due diligence.
Creating an evidence.
For this aspect of it. Exactly.
Yeah.
So tomorrow, in case you are questioned about this in court, you can say that I was a oncologist or I was a general surgeon, etc. Then it was difficult for me to take a call, and therefore I referred the patient to a psychiatrist or a psychologist for an assessment to see how to break this bad news. Yeah. But the treating physician or the consultant definitely has that discretionary power. But like I began, it must be documented.
Yeah. So I think what Mr. Mohan has said, that definitely makes a lot of sense. Just to add to this, what I would say, although if we go by the law, first of all, patient's information has to be first shared with the patient, and only with the consent of the patient, you can share with the family. That's actually what the law says. But in reality, we know the social fabric of our country is very different. It's usually the caretakers who are the primary people involved in the decision, and they are the one who will be the first contact person with whom you will be actually interacting or discussing. So in all probabilities, it will be the family first who will be discussing with you. Of course, if you can sense that there is a possibility of some conflict of interest, there definitely we must take patient's verbal consent and also written consent to allow the family to know about the condition. But in most of the situations, it's the family who's looking after everything. So you can feel that there's nothing, and there's no conflict of interest. That's one thing. Now, coming to the point when the family says, don't tell the patient. Let's take this example. So my advice on this particular issue would be, although I have seen a lot of cases where the family does not let the patient know that you have such a condition or there's a possibility of, deterioration and death. But the family should be explained the benefit of letting the patient know. Because ultimately, if it's time for me to die, I will have a lot of things that I would have on my mind that I would like to do before I go. If you tell me that, okay, you have this much of time, even if I'll cry and I'll be upset and I'll be low and I'll go in depression, again, I will revive out of it and I'll think, okay, I have just 3 months. So in these 3 months, this I want to do. So everybody has some last minute thoughts and some last minute, desires that should be honored. And usually when you tell the patient and the family, they actually come out of it and they start working towards the end, and they also plan the end. For example, some will has to be made. There are a lot of legal and social responsibilities one has to fulfill that should be fulfilled before the person goes. So we have to respect that part. Usually when you let the family understand the benefit of letting the patient know, they will agree with. The second point is, and also when you tell them, see, ultimately the patient is going to come for follow-up. So if you don't tell that this is cancer, but when they see radiotherapy or chemotherapy and they see cancer ward, they will get to know. They are not children that you can hide from them. So that's how you have to kind of prepare them, that it's better to inform the patient and do the treatment. Second thing is, now if the patient says, don't tell my family, again, if there's a conflict of interest and you think, okay, not telling the family, for example, I still remember sometimes patients come and tell my husband that, sir, please don't tell my husband that I'm wearing very high power specs because I'm using lenses and he does not know that I'm high myopic. So that's all right. That's patient privilege information. Patient does not want to share with her husband. That's okay. But in case if it's something like HIV, the patient is HIV positive, and the patient says, don't tell my wife and don't tell my family. There you know that it's going to affect the family. It's going to affect the wife. The infection can spread. So definitely there you have to use your discretionary power, and then you have to, communicate to the family. And there even, you can go against the patient's wishes. So Dr. Padma, just a second, I'll get back to you. So what I'm trying to say, if they say something, we can't just take it as it is. We got to work with them. And as Mr. Mohan says, document everything. When you document everything, that shows that you made a real effort to explain to the patient or to the family. And then if whatever happens, that's you're honoring the wish of the patient or the family. But if you have made an effort, that has to be documented. So this is what is my understanding of the issue. Yeah, Padma, you have a question. Go ahead, please.
Actually, we face the same issue in my father's case. He was suffered with the 3rd stage of pancreas cancer. I asked you, I supposed to start from the beginning of the session, but I could not attend because of that reason, as I discussed with you. Maybe after attending this session, now I understood what we made a mistake. We hide because of my father says, we hide the reality of his health condition. He did not supported us for his further treatment, or we went for the alternate treatment of Ayurvedic. They said there is no possibility here. In that case, we should not go for we don't want to suffer him a lot with the chemos and all. So we went to other therapy, but he was not supported us. He could not understand why we are pressurizing him to take medicine or proper food and all. Now I understood. Of course, we have done what are the other things, will and everything we have done. He has signed. Maybe indirectly he knows something, but he was not supported us for his betterment of the treatment.
So that means he did not cooperate with you for the taking of treatment, or whatever guidelines were given by the therapists that were not followed.
Yes, that was, we faced a lot.
Yeah, I understand. So I think we have a live example in front of us. Unfortunately, I'm sorry to say, Padma lost her father very recently. She was in touch with me for last 3-4 months, and she wanted to be in one of the programs. So she said, I'll attend a couple of these classes and then attend a regular batch whenever it happens. So I think from Padma's experience also we can see that, I mean, till the last he was not knowing, Padma, till the last he was not knowing.
Maybe by the end of his time he came to know. I hope he understood. He discussed with my niece. I got cancer. It seems I won't be alive furthermore, like that he told to my those are all small children. When he is not listening our words, we are making him feed by the small children.
Okay. Yeah,
whom he is like very much. We tried with them also, giving medicines and all, but he told them in the end of the time.
So if I may ask those who were breaking the bad news, when you were doing the breaking of bad news, what were your concerns? What was at the back of your mind? Those were breaking the bad news. I think Mr. Vijay was breaking.
Yeah, I mean, I was thinking like how the person receives the message, right? Probably. I mean, that is the main thing, right? How can I first calm them down, right? Because I know the patient's condition is serious, but at the same time, that may have impact on the, the family also. So how to, calm them down, and how can I, make them understand the situation? That was the thought process going in my mind.
Yeah. So I think Dr. Seema also was the one who was breaking the bad news. So what were your major concerns or the thoughts at the background when you were breaking the news?
So you can't let them lose hope. That's the thing, because till the end, if it is there, you still, I mean, even as a doctor, you feel like there may be some miracles happen. Even if the results are like this. But still at the back, we always feel like, maybe some miracle will happen. Maybe something different can happen.
Now, again, see, this is also another very clear dilemma, and it has its legal implications. So if you are not clearly telling, especially when you know the prognosis is poor or the death is very near, and if you don't let the family, at times they might blame you for hiding the fact and actually doing it with the idea to make money or to keep the patient in the hospital.
Yes.
So that means we cannot go by these emotions, but the whole information has to be delivered in a very sensitive manner. But honestly, it has to be put, in black and white. You cannot, think in this manner that I don't want to, snatch the hope from the patient. Maybe to the patient, you would not like to tell directly everything, but to the family members, you will have to tell, and that has to be documented somewhere. That this is what we discuss with the family. I mean, even, yes.
Without informing the patient, you cannot treat him. Because unless he knows that he is suffering from such a serious disease, and the treatment is also very complex, radiotherapy, surgeries, precautions, and how can you convince a patient for surgery if you are not explaining the problem?
That's what I'm trying to tell you, that ultimately the patient will get to know. It's better to tell the patient and get patient's cooperation to get the treatment. It's actually family who is in denial. More than the patient, it is the family who is in denial, and they don't want to tell the patient. But in reality, it's always good to tell the patient, if not 100% of the extent, but at least they should know what they're suffering with and what is the prognosis. Even that has to be somehow communicated in a softer voice. So that's what we are trying to understand from it. Any other question about it? So if I may ask, who were playing the role of a patient and the patient's family member, how did you feel to be there? Those who played the role of a patient or patient's family.
Rather, it was difficult for us to be in that situation because we know everything about pancreatic cancer. When Actually, practically it was difficult to be in that situation.
Absolutely.
Uh, otherwise, when we break the news, patients are generally very unaccepting initially.
Absolutely.
Very unaccepting. And that unacceptance come out as kind of aggression in the form of aggression most of the times. They generally initially first time they kind of start blaming someone or the other system or other someone. They start with kind of it starts with aggression.
Absolutely.
And it's difficult for a patient to digest this thing. Generally, we have to.
Why me? Why
Yes,
it has happened?
Before breaking the bad news,
Yeah.
if it is not sudden, like malignancy and all, we have to sensitize the patient over a period of time.
Absolutely.
It is much more difficult to sensitize or break the bad news in sudden things, like in trauma or accidental things. Because I am in a multi-specialty hospital, we deal with multi-trauma, polytrauma.
Yeah.
So many times eye is mutilated beyond repair, we have to even remove it. So it is very, very difficult to counsel the patient and make the patient ready for enucleation. Kind of now I cannot be seen. And at least before enucleation, I think at least we have to counsel more than 15 attendants of that patient. Someone or the other will come again and again, and we simply are fed up.
No doubt. I think in such situations, all the more you have to, do the breaking of bad news in a very, very sensitive manner. You have to do, proper counseling, address all their concerns, make them, understand, and then go ahead with it. Otherwise, tomorrow they might blame you for a wrong treatment or a wrong diagnosis. Absolutely.
Rather in oncology, breaking bad news, people are already sensitized. Most of the people are already sensitized. They are prepared. And in oncology, generally, most of the patients attendants, they are in condition of shock first.
True.
They don't.
Yeah. But in both the cases, I think the role counseling would play, the role communication will play. You can handle both the situations effectively, provided we look after that part, whether it is a sudden, acute accident or any acute disease, or it is a condition like cancer where the patient has been coming for a couple of times and they more or less know that probably it's cancer. It's cancer.
It means practically it is very difficult to maintain the balance. You have to tell the truth also. You have to prognosticate the patient. You have to give hope also. And you cannot make the patient that afraid that patient runs away from your hospital. You have to run the hospital also.
That communication and that effort is worth an effort, because tomorrow you will be saved of all the hassle of being blamed for a wrong, or a hurried treatment or a wrong treatment. Yeah, Mr. Vijay, we are going to talk about DABDA. We are going to talk about it. I'm going to share the protocols. We'll be talking about it. Dr. Puneet says, what about the bad news for the patient as well as for the doctor, like complication in surgery? Absolutely. So that means, and especially if you have not discussed this as one of the possible outcomes, we are going to talk about something similar to it in the next session, which is disclosure of medical error. Although complication is not a medical error, but it is similar to it because patient would see it as an error. Any complication for the patient is a medical error. And how do you deal with that? We'll be talking in the next session at length. But breaking of bad news, of course, has a shade of what you're asking. Helaluddin says that, I'm so sorry to read this, that he lost his father to cancer, and you got only 18 days to, that means he was diagnosed at a very late stage. Is that what I'm understanding? That's very sad.
Yes, ma'am. Diagnosis in late time actually. Only got 18 days to treatment, but and on 19th day he has died actually.
Oh my goodness, it was so sad. Very sad. So yes, that means ultimately understanding how do we go about it. Although what protocol I'm going to share with you is something can act as a guideline, but every time you will do it, you will have to actually see how you have to, work on it, because each case is different, each situation is different, each circumstances would be different. So I'm going to share a protocol with you to help you understand how we can go about breaking of bad news. So this whole role play and discussion was to get all of you to understanding that it is not easy. It is not easy for the doctor to do it. It is not easy for the patient to believe it. It is not easy for the family to accept it. And like Dr. Praveen said, there's a denial, there is anger. Actually, that's a psychological process. I don't know if you have read about it or not, but I'm going to share with all of you. It's a psychological process. And if we know that this is this stage of, process, you will know I have to deal with it. So it's nothing new. It is nothing, strange. It's actually how the mind processes the information and goes into denial. And oh, Dr. Sheetal, you look very unwell. Oh my
Yeah,
goodness. Oh my goodness.
I'm just
Oh
sitting.
God.
I'm sounding a little congested. So I said, I'll just say hello. Sorry, ma'am. I just can't sing. Fortunately, on call the next week. So sorry.
So if you feel like switching off the camera, it's perfectly all right. There is no compulsion. But I'm glad that you are still participating and at least interact.
No, I will. Thank you.
Thank you. Yeah, thank you.
Yes, ma'am.
Yes. So we are talking about breaking of bad news. We have discussed this role play we have done. Okay. So this is something I wanted to, talk about. In a study, 79% of the patient and 68% of the family said bad news encounter was suboptimal. So that means when it is done, and if we don't know how to do it, actually, honestly, patients also can see that we haven't been able to do a fair job in breaking out bad news. The reason some of them said, for example, probably sometimes the physician was too blunt. Like Dr. Puneet just now mentioned that initially even he would, tell it in a very straightforward manner. So from your point of view, you thought that I should not be hiding anything so that patient does not blame me tomorrow and so that there is no confusion. But to the patient, it might come as being harsh or rude or being too blunt. Then some of the patients said that the place or the time was inappropriate. A lot of time we do the breaking of bad news or explaining or the prognostication, in the casualty or in the emergency room or outside or in corridor or outside OT, bedside sometimes, in OPD sometimes. So this place is sometimes is not appropriate. And especially when you do it in corridor, the biggest risk is others are overhearing you. And when others are overhearing you, there's a possibility that they might, intervene. They might speak in between. They might even, instigate the patient party later on, and may also, try to complicate the situation. So again, place and time are very, very important. Then some patient got the sense that there is no hope. So like you're saying that it's very difficult to decide, should we say that there's a hope? Should we say there's no hope? So again, patients felt that sometimes out of the whole discussion, they had a feeling there's no hope at all. And then they wanted the physician to balance sensitivity and honesty. So I think these were the dilemmas we all have already discussed, that we really have to strike a balance where we have to be honest, but at the same time, we need to be sensitive so that they don't, feel it coming as a blow or a blunt information to them. So somebody tried to study the gap in what patients want and what they receive. So this study says that 57% of the patient wanted to discuss life expectancy, but only 27% actually did. So that means we sometimes talk about the disease, we talk about the treatment, but how is that going to impact the patient? How is that going to change the patient's lifestyle? So how much is the life expectancy? Sometimes either we are not clear or we are clear, but we are not able to communicate. So all that makes it very complex and we are not able to do it in an honest manner. Then 63% wanted to discuss the effect of cancer on other aspects of life, but only 35% actually did. Again, because we are majorly focusing on the medical management. But how is that disease impacting the patient's life and other aspects of life? That's probably their major concern. So again, like for example, I gave you my example of, having a doubt that I have tuberculosis. I was not worried about tuberculosis or the outcome or the treatment or will I be all that. My major concern was who will look after my kids, who will teach them, where will they sleep, how will I feed them, can I hug them, can they share meal with me? These were my concerns. And I don't think any doctor would sit with me and address my concerns like that. And this is where actually there's a huge gap experienced by the patient party and the doctor. If somebody's device is on, can I request you to mute your device? Okay, so this slide, I'm not sure if you have seen it earlier. In this slide, they're actually carrying a dead body of the patient behind this banner. So in the banner, it is written that this patient died because of the negligence of Dr. So-and-so, and this doctor should be punished severely. This is what is written on the banner. I'm really not sure if any actually negligence happened in the care of the patient, but definitely there must have been a huge communication gap between the patient party and the doctor, and therefore the patient's party went with the assumption that there has been a major carelessness or negligence at the doctor's part. Breaking of bad news is one of the trickiest and most difficult communication, as it involves advanced level of communication. Most of the aggressive reaction you will see occur after the breaking of bad news. Now, for example, like Dr. Praveen was saying that they deny, they become aggressive, they start fighting. Now, when we start reacting to it, automatically this is going to escalate the situation, whereas these are actually the inner processes of the brain or the mind that are happening with you. Especially when the younger generation doctors are dealing with a situation like this, they are not very well versed with handling their own emotions or handling the emotions of the patient party. So many of you, by now, you must have become seasoned in breaking bad news or addressing this part. But I am sure when you were young or when you started your practice, you must have also experienced similar challenges where you had difficulty, talking to them, finding right words, finding right vocabulary, finding right expression, finding right way of delivering, finding right tone of voice. And all this is required when it comes to breaking of bad news. You really need to have a great experience in handling emotions, which most of us lack. It only comes with, lot of mistakes that we realize, okay, this is how I have to, really good at words, or I have to handle patient's emotion, and have to also control my emotions. Because ultimately there is fear, there is anxiety, there is a fear of reaction, retaliation. So that those emotions are within you. So definitely you have to handle those emotions. You have to handle the emotions coming from the patient party, and then you really need to be good at words and tone of voice and body language and your overall communication. So a word of advice that I would like to give to everyone, and I really tell everyone, that please build good rapport with every patient, because you never know which case might turn into an emergency and may have an unanticipated outcome. If you have built good rapport, if your patient knows you, if your patient sees you as a responsible and careful doctor, whenever something like this would happen, they would not blame you. So if you are able to create familiarity with them and have an impression on them that you are a responsible person, you are transparent, you're honest, you're accessible, they go back with the idea that you have been a responsible and good doctor. Studies have actually shown patients and families are less likely to be aggressive with the doctors they're familiar with. So actually creating familiarity by addressing their queries, by regularly updating them and involving them in decision making. If we can look after these three things, trust me, slowly they will start having this way that, you have done your job well. Dr. Sheetal, do you want to say something? I think I can see your hand.
Ma'am, there's one thing that I wanted to ask. What happens is that, see, the way I speak and the way a person perceives something can be, there can be a very big mismatch.
Yes.
I can give you my own example. When I'm talking, I tend to be very visual. I tend to use my hand. My eyes turn big because they're generally big. So, so the expression becomes, a little different. So somehow the body language, like you taught us, I think that I love that session completely. However, what you say and how it is perceived, there can be a real big gap in that. And I think, yes, there are lots of ways of communication and all that also. But sometimes, and I think there's a big difference in also the type of people we're dealing with. Our country comes with a whole, mix of people from various places. So there's a sect that's generally very aggressive. There's a sect that may not say something, but you don't know what they're thinking, and you don't know when the backlash will come. Because I think when
so, Dr. Sheetal, I think what you're asking, we are going to talk about this in this session. So that will give you an idea that why we should, attend to the patient party, till the end, so that you get an idea what is the patient thinking. So we are going to talk about it. I think most of your doubts will be, addressed. And I completely agree with you that there can be huge communication gap in the way that we are saying and the way it is interpreted. So that means I have to make sure that my verbal, my non-verbal, and my body language, they are all to the best of its form, so that they make the right communication. And you really need to have a feedback of whatever you have said by asking, have you understood? Is it clear? Is it do you have any doubt? So when you are able to get this feedback from them, you get an idea how are they taking it, are they understanding, are they okay, are they disagreeing, are they angry? And from their body language also you get an idea how they are reacting to it. But a lot of other things will be covered in the session. So maybe towards the end you can ask if something you wish to ask. So again, as I said, transparency and honesty goes a long way in having an impression on the patient that you are doing your job in the best possible manner. So when they come asking for something, and if we answer them, if we address them, if we explain them, they feel satisfied that their questions have been addressed, their concerns have been addressed. I think one thing that we need to understand, whenever the patient is in critical condition or has a serious diagnosis, the family is looming under the greatest fear of life, and that is fear of death. Anybody's behavior and thought process and reaction will change when you are under fear of death. Those of you who have recently seen this happening with you, and I think even COVID situation has shown us very closely when we had our family members who were really seriously ill and we were really worried about them, fear of death completely changes the way the world appears to you. So we need to understand that we need to not only look after the patient, but also understand the family's concern. They are the one who are actually looking after the patient. They are the one who are involved into the decision making or the patient care. So naturally, their emotions need to be addressed, which sometimes we do not want to, address, thinking that that's not my responsibility. Even the nurses, residents, and paramedical staff involved, especially in critical care areas like emergency, like OT, ICU, labor room, they need to be sensitized that they need to be far more compassionate and understanding of the family's need. So when they come asking that we want to see the patient, we want to, meet a family member, we can't be rude and blunt and say that no, only you can come during visiting hours. So we really need to be more accommodative and understanding to the family's needs. So the breaking of bad news should be done by the doctor who has been regularly attending the patient, because by now you have built rapport and also you know the patient's condition, and it should preferably be done by the senior most person present in the system. I'm going to share the protocol with you. Of course, you can modify the protocol as per your requirement, but this gives us some idea about how you can design your breaking of bad news. So there are 4 P's in it. The first P is preparation, where you really need to prepare yourself about what you're going to say and how you're going to say. Then the place where you're going to do, and then also preparing the patient for receiving the information. Then performance, that is second P. Third is palliate, how do you really take it forward, and then plan. So when we talk about preparation of the physician, it's very important to first of all be 100% sure of the information that you are going to share. If there is even a slightest element of doubt, and in front of patient or their family member, if you will fumble or you will appear inconfident or not informed, you will lose the ground. So know about your patient, know about the condition, know about all the tests done, know about the reports, so that when you're going to do it, you have to be 100% aware of what is happening. At least you have gone through the case sheet, you know what is the stage, what is the other, wherever you referred, what is the second opinion, what is the report, all that you have to be really ready with, because they are going to ask you about it. So before you actually break bad news, it's good to make a connection with the patient or the family. So naturally, when you will enter into their room, and if they are sick, definitely you will not ask, how are you? There will be a couple of questions that will help you make connection. For example, how's your fever now? Did you eat today? Did you feel, could you walk today? How's your pain? So that means you are starting with something not very specific and you're going to move to specific, but making connection with the patient and the family will open a platform for a dialogue. Naturally, this might take a lot of time. Some people will slightly listen to you. For example, in this role play, in 5 minutes, you could finish the role play, but in reality, that will not happen. In reality, it might take 15 minutes, 20 minutes, sometimes even half an hour. So it should never be done in hurry. Be mentally ready to spend some time, because they may want to ask you some questions, they may want to clarify certain things, they may want to understand the options available. So you can't say, okay, we'll discuss it next time. So be mentally ready to spend some time with the patient and the family. And interruptions like phone call, visitors, somebody waiting outside, or you have to go and see somebody, they again upset the person. When you're going to break the bad news, you really need to have time and mentally available with the patient party, so that they feel that you are connecting with them and doing it in a relaxed manner. Again, as I said, do not delegate. If you are the doctor who has seen the patient, if you are the one who has been attending the patient, it should be done by you. I was taking a session for Reliance Foundation Hospital. So a very interesting fact that they shared with me, they said, if a surgeon operates and the patient is sent to the ICU, it is the ICU doctor who is expected to break the bad news. Now imagine if the surgeon has admitted the patient, the surgeon has operated the patient, if the surgeon has, treated the patient, and then you finally say it's the ICU doctor who will break the bad news. I don't think that makes sense. And when you delegate like this, there itself you lose the ground. There itself you lose the trust of the patient party, that the surgeon is not ready to come and talk. In a lot of programs, I get to hear that the surgeon asks the anesthetist to go and break the bad news. So if I may ask Dr. Sheetal, what is your experience? How many times it has happened with you where you have been asked to go and break the bad news?
Yes, I completely agree here. There are situations, thankfully, I must say, I've not had the ultimate breaking the bad news experience, thankfully, but yes, the patient is going bad, he's lost a lot of blood and this and that. So, of course, I would say that some of my colleagues would ask me to go ahead to just sort of create that ground wherein they can come out and then say it later. So yes, that this does happen, but I tend to always talk to patients much before, so they sort of know me by face.
Yeah.
But yes, I have seen situations, I've heard of situations where they've said things like oh, the surgery went well, but he just didn't wake up out of anesthesia. There are things like that.
Yeah.
So it's not like that. I mean, evidence tells you and science tells you that we must get our facts right. There is no situation in the book on this earth wherein a patient is not waking up out of anesthesia, and not in modern day anesthesia at all. So yes, it's very important what you say. Absolutely.
Yeah. It's very important to own the responsibility of doing the breaking of bad news. A lot of time in government setup, they'll send the junior resident to go and break the bad news. Again, not a good idea. Consultant would send the residents to do it, and they would not come in the picture and talk to the patient party. So again, if you are delegating to a person who is very junior and not very experienced, you can definitely expect some aggression and reaction in that case. So therefore, I emphasize that please do not delegate and do it yourself if you have been the treating doctor. Now, coming to the place, as I said earlier also, it should never be done in corridor or in an open place. There's a risk that others would overhear and may try to, influence the patient party or may misguide or instigate them. So it's always good to sit down at a separate place. Of course, now in most of the big hospitals, we have counseling room. I think most of the corporate hospitals have well-established counseling room, but in government sector, still we miss that part. We do not have counseling room. We do not have, a place where you can make the patient party sit and talk. And therefore, usually it is done in corridor or outside the OT or outside labor room. There's a risk involved. Let me tell you, in an open place, there's always a risk involved. There can be violence, there can be aggressive reactions coming from there. Ensuring patient's privacy is very important, especially when there can be a conflict of interest. It's always good to ensure who should be there when you're going to break the news, rather than just going and telling them what the diagnosis or the outcome is. It's always a good idea to involve somebody, maybe from the patient party, a relative who has been in your regular touch. As I said earlier, also identify primary caretaker. If you identify the primary caretaker and if you have been regularly in touch with the primary caretaker, that person will actually come to your rescue, because that person will be kind of a witness to all the efforts that you have done or all the communications you have made. So even if it is required to note down in the patient's file that this is the person who should actually be involved at the, in case if we need to talk to the family. Of course, a person like social worker or a senior nurse or a counselor can also be of help, because they'll be able to, calm the patient party or, comfort them. Glass of water, facial tissues. I mean, these are all simple things, but they go a long way in making the other person calm down. And, if you offer a glass of water or facial tissue. Before you actually break the bad news, it's important to assess patient's starting point. So if the patient has been referred to you from a place where the patient was already investigated for a disease and they have an idea that this is cancer or this is, a particular condition, so they have an idea. But a lot of time they will be when the patient has just no idea about it. So the starting point will be very different in both the cases. For example, when you ask questions like, what do you know about your condition? Or what has the referring doctor told you? Or what is your understanding of the reasons why we did this? So this will give you an idea how much the patient knows or how ready the patient is. Protocol also says, before you divulge anything, ask what does the patient want to know. Although I don't think we follow something like this, we normally go and tell whatever we think we need to tell the patient and the family. I mean, but protocol says you can ask them, do you want to know everything about your condition, or it's just the, your disease or treatment that you are looking for. So again, you need to really check what is the patient's readiness to receive. So for example, if it's the patient who has come alone and it's a serious news, you can even postpone the announcing of bad news. You can ask the patient to come with her husband or with her family members. And also, before you actually discuss, you can ask them that I'm going to talk to you about your condition. Do you want to call somebody? Do you want to ask somebody to be with you? Because there can be, the patient may faint, or the patient might, like for example, Dr. Puneet said, the moment the patient got to know that I have to wear a specs, she fainted. And I mean, and if there is no attendant, if there is no relative, it becomes very challenging to handle that situation. And asking them very openly, clearly, whom do you want to engage in the discussion, will give you an idea whom all they want to talk about their condition. Now, this is another study that tells, it's a study in UK where they studied around 2,000 patients, cancer patients. 98% wanted to know if the illness was cancer. That means patients' desire to know is it cancer is actually very intense. They want to know, because see, at the moment you get to know this is this or not, you have a different, roadmap in front of you. And then you start thinking, how do I want to deal with life now? And 87% of the patients preferred as much information as possible. So this idea that patients don't want to know about their condition, or they don't need to be informed everything is again a misnomer. I think we have to respect patients' information need and make sure that we, answer their questions and address their concern. So when you will interact with the patient, you will be able to see if there's any illness denial. Like Dr. Puneet was saying, Dr. Praveen was saying that they usually deny, they are not able to believe it, or there will be wishful thinking. No, I'm sure some miracle will happen, something will happen, and things will change. Or they may have unrealistic expectation of treatment. So if you're able to identify, and if it is very intense, please address them appropriately right then and there itself, because later on this can be a big issue. In case if there is any misinformation, correct that misinformation. Don't leave it as it is, because later on again they may say that I mentioned this to you last time, but you did not say anything, and now you're saying no, this condition is such and such. So it's always right to correct any misinformation that you can see. And if there is bad news, you think the patient will not be able to take it, no harm, tailor it. You can stagger it. Maybe in 2 or 3 settings you can say, or like Dr. Sheetal says, that she would go and talk to the patient and the family first, and then the surgeon would go and break the news. That means you have already kind of prepared the patient or the family about what is coming next. So staggering helps to prepare the patient or the family. When you're performing it, when you're sharing the information, be sensitive but straightforward. So any effort to soften the blow or to minimize the severity is going to create confusion. It's going to create vagueness, and tomorrow you will be caught hold for not being very straightforward. So it's very important. Of course, we have to be sensitive. We have to understand that it's going to come as a blow, but at the same time we need to make sure that we have been able to tell the facts in actually a very precise manner. When you're breaking the bad news, use simple language. Avoid all technical jargons. A lot of time there can be confusion just because you use the technical jargon that the family did not understand and they did not get the exact condition. When you're speaking, don't make it a steady monologue where you are just kind of reading a news for them. Pause in between. So when you will pause, they'll get a chance to ask a question or assimilate what you have said. So that will give them a chance to speak or to say something. That will give you a lot of opportunity to observe and see how is family taking it, how is patient taking it. So pause in between, use silence, body language. All this is going to play a role in communication. So Dr. Sheetal, your question gets answered here. Even if your words have been different, but if your body language, tone of voice communicate compassion, empathy, being responsible, they get an idea that, oh, maybe this doctor speaks little loud or maybe fast, but that does not mean that this doctor is rash or is arrogant. Very important thing, after you have said everything, ask for understanding. So make sure that after you have given all the information, you say them that I have explained you about the condition. Do you have any questions about it? They will mostly say no or yes. And then say, can you explain me in your words, what have you understood? This will give you an idea, have they really understood whatever you have explained to them? Because then you will be very sure that they have understood your message clearly. So we have discussed this earlier also. Most of the communication is actually non-verbal. So even if your words go a little here and there, but your body language, your tone of voice, facial expressions, eye contact, everything plays a very big role in comforting the patient or communicating that I am with you in this. So some of the things that you have to be really careful about when you are going to do the breaking of bad news or in the process of doing it. When you enter the room, greet softly, make eye contact. I think making eye contact is very important. When you don't make eye contact, it might appear as, what do you think if you don't make eye contact, what will happen if you avoid eye contact? How can that be taken as?
they may think that we are hiding something.
Absolutely.
Yeah.
They may think you're hiding something. They may think you are scared of something. You are guilty of something. Or you are responsible for what has happened. So not making eye contact can have, the real confusion. It's always good to make enough eye contact to communicate, of course, confidence, and also the transparency and honesty. Your posture again plays a very big role, and you remember that we had seen that when you make a relaxed, open posture where they feel that you haven't come scared or you're not, you know. Anxious about the situation. Leaning forward again shows that you are trying to connect with the patient and patient's family. Tone of voice plays a big role. Make sure that your tone of voice is not rash, rude, authoritative, intimidating. I think care has to be taken. So the tone of voice has to be appropriate. Allow the patient to express. That's very important, because that will give you an idea. Are they understanding? Are they agreeing? Are they denying? Are they blaming? Are they seeing us responsible for it? Allow them to express. So when they are saying something, listen attentively. If you are doing something and if you are not attending to them, they will feel that you are not listening attentively. So listen attentively, nod whenever appropriate. That shows that I'm listening, I'm understanding, I'm agreeing with you. There will be times when the patient or the family might emotionally react. They may cry, their voice might go up. They may even say that you haven't done enough. I told you earlier also, and you did not listen to me. If you can avoid being too reactive to it, you will actually be able to help them vent out. And if they're able to vent out, a lot of time they calm down after they have vented out. So comforting the patient or the family members with the appropriate verbal and non-verbal gesture again would help in helping them see that you are with them in this situation. So if I may ask you, what are the different ways that you can start this conversation? Any examples? How do we normally start the conversation? Dr. Puneet, how do you normally start the conversation, if I may ask you?
Ask the patient to sit, and then tell him about his condition. And I gradually, talk about the things.
Yeah. So there are, a few dialogues I'm sharing with you. To some, it might appear more like a dialogue, but if you can bring this in your way of communication, you will see its impact, in making the patient feel that you are with them in this conversation. So for example, when you say, I really feel bad to tell you that this is what your reports say. Or when you say, unfortunately, I have some bad news to tell you, your reports are not really very encouraging, or the news is not very good. Or when you say, unfortunately, I got your test report seen by 2-3 people to be more sure of your diagnosis, but unfortunately there's no doubt about it, and the test results really are very confirmed that it is such and such. So that means when you start this conversation in this manner, that shows your human side. That shows that you are understanding that this is something which is difficult for the patient and the family to take, and you are sensitive to that, but because you are responsible for informing, so you are doing it. So if you try to integrate this in your way of communication, you will see its positive impact in in the way patient will take it. So how do patients experience bad news? Bad news result in a cognitive, behavioral, or emotional deficit in the person receiving the news. There is a block, there is a blank, there is complete, just disconnect with the world for a while. So whatever you are saying or explaining, honestly, they are not able to take in, because they are not there mentally. They may be physically there, but they are completely loss in their own illness. So of course we can't change the news, but we can actually make the news worse in case if we don't deliver it in the right manner. And also, we can give them a realistic hope where they get to see how they can, take life or look into future. The usual response of the patient is usually either they will start crying or they'll become silent. They may ask you, are you sure? Is it my report? Are you very sure? Maybe the report is not right. Have you got this checked once again? Or they may say, don't tell my family, don't tell my husband, don't tell my children. This is usually how they will respond to the news. This is another study that says, in a study of 100 patients, diagnosed with cancer, 54% responded with shock, 46% reported with fright, 40% accepted it, 24% reported sadness, and 15% said that they were not worried. So see how everybody reacts differently to the bad news, and we need to know that this is how the patient party might react to the situation. So this is the psychological response, and it is called DABDA. DABDA is denial, where they may actually be in shock and they may just deny and may not accept the reality. A is anger. They will be angry, unhappy, aggressive, revengeful, and usually they'll blame you or somebody for the mishap. They may say, I brought him late, or they may say, you did not do enough, or they may say, the previous doctor has spoiled my case. So they may try to blame, and take out anger on others. After anger, it's usually bargaining. So once they start realizing, okay, this is the reality, they'll usually, ask, okay, is there any other treatment? Can we go to another doctor? Is there any other center where we can get the treatment done? We are ready to even go to foreign country to get the treatment. If there is any treatment, let me know. I'm ready to take my patient there. So that means what they are trying to do, they are trying to, bargain by seeing if anything can be done for the patient. Again, slowly, when the reality is seeping in, they will actually become quiet once they get to see the reality. And that's depression, where they will be sad and upset and will not react to anything. And finally is acceptance, where they will accept the reality, or they may start understanding that, yeah, this is something that has happened and we have to now take it forward from there. So how do you deal with it? Denial has to be dealt with information. So when they are in denial, we can't be angry on them being denied. We got to help them see the reality by providing them evidence of the, disease. For example, if you have CT report, or if you have MRI, or if you have blood report, when you show them the report, they get to see, okay, this is the reality. So they may say, no, maybe this report is wrong. And when you say, okay, this report could be wrong, but what about this report? Even this report corroborates with the finding. So slowly they will understand, okay, this is the reality. Anger has to be dealt with, staying calm. Usually at this stage, when they become angry, we retaliate. And that is where the breakdown happens. That is where aggression and violence, risk of aggression and violence is there, because we start retaliating. We also become aggressive. If we can handle anger by staying calm, by listening to them, being supportive, and then helping them see the reality, that will help us in handling the situation effectively. When you see them bargaining, empathize, don't be annoyed on it that money can't buy everything. What do you think? We doctors are not good, foreign doctors are good, or that particular hospital has more treatment or better treatment. That's not true. There's no need to get angry on it. Just empathize that if I was in that position, even I would have tried my best effort to get the best treatment for my family member. But of course, when you help them see the reality and assert, they kind of start understanding that this is what is the reality. When you see them depressed and quiet and sad, that is where you need to give them direction, where you have to tell them what needs to be done next. So maybe you'll say, okay, I think we now need to, talk about the treatment part. If you want to go home and talk about the condition and come back and discuss. So whatever it is, to kind of give them direction that what needs to be done. And once they start accepting it, that is where you need to encourage them and support them and show them the, realistic hope of the outcome of the treatment. Empathy, I think we have talked a lot in our previous sessions. It's a great tool to create solidarity. I think this is one thing that usually is missing in our communication. If you can bring in this, I think you can win your patient. Put yourself in that position. If it was me or my family member, how would I feel? And what would I expect from my treating doctor? You will never fail to be compassionate with your patient. You will be able to see how a disease impacts a patient's life, and their reactions are so natural. They're denying their anger. It's very natural. You will not judge them for being aggressive or being rude, but rather you will understand that this is part of how the patient or the family will accept it. So these are a couple of ways where you can, express empathy by saying, I can see how upsetting this is for you, or I know you were not expecting this, but I'm really sorry to tell you this. This is not the reality, or this was even difficult for me to believe because I didn't expect something like this, or I was also hoping a better result. So that shows that you also were concerned about the patient's, diagnosis. Now it's just like Dr. Puneet was saying, that what about the doctor? Of course, he's also equally affected, or she's also equally affected. Yes, clinicians also would have their own concerns. So if I may ask you, what are the usual concerns the clinicians would have in this situation? What do you say? What do you think will be the concerns?
Feeling of helplessness?
Definitely, especially when you didn't expect something like this. Some of you said that when you are going to tell them about the reality, that's going to actually take the hope from the patient. We are going to destroy patient's hope. So that's also one of the concern one would have. What more? What more? So I think, first of all, uncomfortable about the patient's expectation. So when they come with very high expectation or unrealistic expectation, it's very uncomfortable to tell them the reality or break the bad news. Again, fear of destroying patient's hope. We talked about it, that that's something, again, we have a dilemma. If we tell them the reality, the patient will lose hope. But if we don't tell them, we are hiding. So there's a conflict within the doctor. Then also sometimes we feel inadequate in the face of uncontrollable disease, especially, for example, if we saw COVID situation. I'm sure a lot of us felt very uncomfortable that we can't handle it, and we see the patients dying or becoming critical and being uncontrollable. So there's a feeling of inadequacy, and then we are not prepared to manage the patient's anticipated emotional reaction. I've deliberately written anticipated. We think these emotional reactions are absurd. They are not absurd. They are going to be there. They are going to be there. Only thing is, we are not prepared to manage them. So therefore, we feel, we are anxious to deal with that. And sometimes when we have painted a very optimistic picture for a patient, you feel embarrassed because the outcome is not as per the expectation. So I remember one of the taglines, I'm sure many of you may be knowing, "Ghar se aiye, surgery karaiye, office jaiye." This was a tagline of one of the eye chain. So I'm sure when the patient lost vision or had nuclear, vitreous hemorrhage or nucleus drop, this something like this, you are actually giving them a very, unrealistic picture. So I think the idea is, give them realistic expectation, accept your professional limitations. We are not God, we are human beings. So we have to make sure that we tell them that we will do our best, but still not all 100% is in my control. It's very important to learn the emotional control, because patient is bound to react. I don't have any control over it, but I can control my emotions, my reaction to it. And that is a learned process which can be learned. Keeping the family updated, letting them know the reality, letting them know how the patient is progressing, will prepare them for the eventuality. A lot of time when we don't tell them, the possibility of the outcome, and suddenly when it comes as a bad news, they are shocked. So it's very important to keep them updated. And then very important is whatever communications you make with them, please document. So the thumb rule is document what you communicate and communicate what you document. If you follow this, definitely you will be far more comfortable. So once you break the bad news, the patient fears that I'm going to be left out, I will be abandoned. Very important here is to once you have given the news, even if the patient has to be moved to another hospital or has to be referred to another center, it's important to establish a plan with them, treat their current symptoms, discuss their treatment plan, establish a time for a follow-up appointment. Maybe they, even if you refer them, they want to come back to you for follow up and discuss with you and take your opinion. Most important is, I think, to reassure them that you are not going to be abandoned, but you are going to be handed over to the next doctor. So arrange for appropriate referrals. If you know the doctor to whom you are referring, you are giving them a referral note. If you can give them contact details, even call the doctor and tell them about this case. So that will be more like, directly briefing up the next person, and they will know who is coming and what is the condition. At this point, if you can involve people who can provide emotional and practical support, it will actually unburden you of the responsibility of addressing patients' emotions. So involving people like family, friends, social workers, spiritual counselor, peer support group, it's a good idea. It's a good idea because they can handle the emotions and they can, provide the emotional support. I think disease and death, how it impacts anybody's life, it can only be understood once we, go through that journey. I don't wish anything of that sort, but personally, I could actually see this very closely when I lost some of my dear ones. And that's how I became all the more sensitive to the idea that it's actually, it's very painful for the family. So this is the protocol of breaking bad news. Any questions about it?
And sometimes when you are discussing the poor prognosis and difficulties of the treatment, the patient, the body language of the patient is that he thinks that everything can be purchased with the money power. Even if very serious diseases, when you discuss, how to, in the end, the doctor साहब तो खर्चा कितना होगा, जितना तो ठीक तो हो जाएगा सब कुछ. So after half an hour of explaining or 15 minutes explaining, when the patient is like, उस चीज को कैसे, how to handle such situation? You cannot.
अगर पेशेंट ये पूछ रहा है ना कि खर्चा कितना होगा, तो चलो तो ये फाइनेंशियल कंसर्न है, this has to be addressed. There's no doubt. This has to be explained because a lot of treatment are very expensive and outcome is still not 100% sure. So there we have to be very careful in telling them that this is the expense and the outcome is still not 100%, so that put the ball in their court to decide whether they want to go for this treatment or not. Because अगर हम कहते हैं काफी उम्मीद है ठीक हो जाएगा, घबराइए मत, आप इलाज करवाइए, सब ठीक हो जाएगा, अब मैंने बड़ी वेग सी स्टेटमेंट दी है, कल अगर आउटकम 100% नहीं आया, वो आकर मेरी गर्दन पकड़ेंगे. और अगर मैंने कहा कि देखिए इस वाले केस में चांसेस ऑफ रिकवरी बहुत कम है, शायद सिर्फ 20 या 30% है, लेकिन अगर आप चांस लेना चाहते हैं, हम ये ट्रीटमेंट कर सकते हैं, ये ट्रीटमेंट हेल्प करती है, लोगों को हेल्प करती है, इस केस में हेल्प करेगी नहीं करेगी हम नहीं कह सकते, हम सिर्फ कोशिश कर सकते हैं, और ये इसका एक्सपेंडिचर है. सो आई एम वेरी क्लियरली पुटिंग द बॉल इन द कोर्ट ऑफ द पेशेंट कि यू डिसाइड वेदर यू वांट टू गेट द ट्रीटमेंट और नॉट. जब भी हम डिफेंसिव प्रैक्टिस करते हैं और यहाँ पर ये रहता है कि आई विल लूज द पेशेंट इफ आई टेल देम द फैक्ट, वहां पे पेशेंट हमें पकड़ सकता है. बट अगर मैं बहुत ऑनेस्टली ये कह रही हूँ कि भी इसमें ये रिस्क है और ये पॉसिबिलिटी है, यू टेक अ चांस. अगर वो पेशेंट डिसाइड करता है कि नहीं जी हमें नहीं कराना, इट्स बेटर, बिकॉज अगर उसको हमने कर दिया और कल को वो पेशेंट उसने अगर वो केस अगर कोर्ट में चला गया तो अगली पिछला सारा हिसाब बराबर है. आई विल ऑलवेज से डोंट प्ले दैट गेम. Even one case is enough to spoil anybody's life. So और अगर वो किसी और के पास जाएगा भी, वो ये क्वेश्चन जरूर पूछेगा, क्योंकि वो आपसे बात करके जा रहा है और आपने बोल दिया है कि उसमें सिर्फ 30% चांसेस है। आप चांस लेना चाहते हो, आई एम विद यू, आई विल गिव माई बेस्ट, आई विल डू माई बेस्ट, बट आई कैन नॉट गिव यू 100% एश्योरेंस। वो वहां जाते ही पहले पूछेगा, डॉक्टर साहब कितने % चांसेस है रिकवरी के, क्योंकि आपने उसको ये बात बोल दी। और वहां पे आई डोंट थिंक एनीबडी विल बी फूल टू आंसर लाइक दिस के 100% चांसेस है। डेफिनेटली दैट पर्सन आल्सो विल गिव अ वेरी रियल। पर अगर आपकी रेपो अच्छी थी, आपका बिहेवियर अच्छा था, आपने उनके क्वेश्चंस को एड्रेस करा, दे विल कम बैक टू यू कि नहीं, ये डॉक्टर साहब ने कम से कम तसल्ली से बात तो सुनी और अच्छे से ईमानदारी से सब बताया, झूठ नहीं बोला।
I think, ma'am, you have to design a course for ophthalmology separately because the things that are happening in ophthalmology are different.
I know. पर डॉक्टर साहब, मेरे को ये लगता है, मैंने शायद पिछली बार भी बताया था कि डॉक्टर KPS मलिक जो कि सफदरजंग में HOD थे, तो मैं एम्स ऋषिकेश में सेशन लेने गई, तो मुझे वहां पे उनसे मेरी मुलाकात हुई। वो कहने लगे बहुत बारी पेशेंट की आईसाइट चली जाती थी, बिल्कुल जीरो विजन हो जाती थी, तो भी पेशेंट आकर थैंक्स करके जाता था, डॉक्टर साहब आपने पूरा एफर्ट करा टू सेव माय आईसाइट। आई ऑलवेज एम्फसाइज, जिसको हम वैल्यू नहीं कर रहे वो बहुत इंपॉर्टेंट है। क्लिनिकल स्किल को मैं अंडर एस्टिमेट नहीं कर रही, ऑफ कोर्स यू हैव टू बी बेस्ट इन योर क्लिनिकल स्किल, पर दिक्कत कहाँ आती है, जहाँ के क्लिनिकल स्किल्स बहुत अच्छे थे, आउटकम एक्सपेक्टेड ही नहीं था, आपने रेपो बिल्ड नहीं करी, पेशेंट आपको ब्लेम कर रहा है। अगर आपने रेपो बिल्ड करी हुई है, आउटकम अगर पुअर आता है, पेशेंट को ये लगता है कि आपकी तरफ से कोई कमी नहीं थी, दे विल नेवर ब्लेम यू। आई वुड से बी रेपो बिल्डिंग करिए और ऑनेस्टी के साथ अपना एक्सप्लेन करिए। पेशेंट जाता है, जाने दीजिए, 10 में से अगर एक पेशेंट चला भी जाएगा, कोई काम नहीं खत्म। और ऐसा कितने केसेस होते हैं जिसमें हम ऐसे थोड़ा उल्टा सीधा बोल के एक पेशेंट रख लेते हैं और बाद में वही केस कॉम्प्लिकेट हो जाता है। और देन वी हैव, इफ आई डोंट वांट टू कोट दैट केस हियर, बट मेरी किसी गायनेकोलॉजिस्ट से बात हो रही थी, जो राजस्थान में केस हुआ, जो डॉक्टर का, the lady doctor who committed suicide, with all due respect to her, and it's a very sad situation. I mean, I overheard from these gynecologists said this case was a very high risk case, it should never have been taken into any nursing home. तो जब आप आउट ऑफ उसमें जाते हैं ना, रिस्क लेने में जाते हैं, then you are calling for problem. चैलेंजिंग केसेस के लिए अगर आपके पास पूरा मैनेजमेंट वो है, सिस्टम है, बैकअप है, गो हेड।
But at the same time, I think this is a different case.
Yeah.
But at the same time, if the facilities are not available in the town or nearby cities, and if you're taking a chance, I think that should also be considered.
पर मुझे नहीं पता, see, I don't know the reality, so I cannot comment on it. But my only thing is, see, each one of us is responsible for our own safety.
I think the best is to promise less and deliver more.
Deliver more. I think that's the best thing. प्रॉमिस है, लेकिन ओवरऑल अगर आपका कंडक्ट अच्छा है, बात करने का तरीका अच्छा है, यू आर एड्रेसिंग देयर कंसर्न, एक्सप्लेनिंग देम वेल, दे आर सैटिस्फाइड। मोस्ट ऑफ द पेशेंट्स, अल्टीमेटली इट कम्स टू कि डॉक्टर कैसे लगे, अच्छे थे, तो देन दे आर लेस लाइकली टू बी एग्रेसिव विद यू। So if there are no more questions, we'll quickly move on to the presentation. Who all are going to make the presentation today?
I am making, madam.
Okay. So
Vijay Kumar.
Mr. Vijay Kumar के अलावा anybody else is ready with the presentation? ठीक है, I think Mr. Vijay, you can start. I'm giving you the.
Sure.
Sorry, आपको screen share करने का वो देना है ना?
Yeah.
Yes. Go ahead, please. Yeah.
Okay, while I share the screen, I request all of you to have the paper and pencil or paper and pen with you. Let me share my screen. Hope you are able to see my screen, and am I audible?
Yes.
Okay, so good evening, everyone. My name is Vijay Kumar. Today I'm going to present about introducing a topic in an interesting way. Okay, So before I get into the topic, actually, I would like all of you to do a very small activity, right? So that is why I'm asking you to have a paper and pen with you. So in this activity, what we will do is, we have 4 figures here, right? Triangle, rectangle, circle, and small rectangle. So using these figures, I will give you instructions to draw a small picture. It's a very small picture. It's a very straightforward, simple and straightforward. So while giving instructions, in case if you have any clarifying questions, please type your questions in the chat. But only thing is, when you type your question in chat window, just send it to me directly, because I don't want others to get distracted, right? So hope you know how to do that, right? Go to the chat window, and it says to everyone. In that to everyone, just change my name. From everyone to change my name, and I will receive your message directly. Okay. So that is the one request, because I don't want others to get distracted. So are you ready with paper and pencil? Are you all ready with paper and pencil? If yes, can you please?
Yes,
okay.
yes.
Okay, thank you so much. So let's move on to the activity now. So the instructions I will give you, and of course those instructions will be displayed on the screen, just for your reference. So first, draw a triangle. Okay. Then second instruction is draw a rectangle below the triangle, but only the requirement here is the length of the rectangle should be same as the base of the triangle. So I know you all know about base of the triangle and length of the rectangle, but just for your reference, I gave here what is the base and what is the length I am referring. So the requirement here is you need to draw a rectangle below the triangle, but base of the triangle and length of the rectangle should be same. Okay. Then draw a circle inside the rectangle. Okay. And then draw 2 small rectangles below the bigger rectangle. So below the bigger rectangle, just draw 2 small rectangles. So I gave reference what is meant by small rectangle. You need to draw 2. I hope all the instructions are clear, and this is the activity which you have to do. That's it. So once you are done, maybe you can just type yes in chat window. Have you completed?
Yes.
Okay, I think looks like most of the people have completed it. All right, thank you. So now, can I request, 1 or 2 people to show what you have drawn? Do you want to volunteer for it? Who want to volunteer? I just want to see like what you have drawn.
Bring it little closer to the camera. Only then we will be able to see. Little more closer. Okay.
Okay, thank you. Thank you.
Visible or not? I've drawn this.
Yes, thank you, ma'am. Thank you. Anyone else would like to see? Show?
Oh, I can see one more. Very nice.
Yeah. Very nice. So, most of you would have drawn like this, right? So how many of you have drawn either left side or right side figure? Can you say yes? Can you type? Okay, so Dr. Seema says no. Dr. Seema, can you show like what you have drawn? Okay. All right. Yeah. So actually, I asked you to draw a circle inside the rectangle, but looks like you have drawn it in the triangle. That's fine. Okay. So, but most of that, I think people have drawn either as a left side picture or a right side picture. That is because you have assumed some things. Because when I say draw a circle inside the rectangle, most of you would have seen something like this, right? Here. But actually, when I asked you to draw this picture, this was in my mind, right? I want you to draw circle on the right side of the rectangle and two small rectangles on the left side of the bigger rectangle, right? But then I also told you, you can ask me any clarifying questions, but none of you have asked me any questions because you assumed, right? When I'm asking you to draw a circle in the rectangle, you all assume that it has to be center, right? And similarly, when I asked you to draw two small rectangles, you all assumed that it should be either side of the rectangle, right? But you could have asked me, but you haven't done. Why? Because you assumed something. So the objective of this activity is basically to highlight the same thing. We were talking today also about the communication gap, right? And Dr. Sheetal also said, what I want to communicate may not be perceived in the same way by the patient or family. In the same way, here, the objective of this activity is to highlight the importance of asking right questions without assuming or judging, right? When we are on the receiving side, right? And if we are receiving some message, we need to ensure that whatever we are understanding is consistent with sender's expectations, right? But we do a lot of assumptions. Similarly, from the sender side, when I am giving you some instructions, probably I should have given you, instructions without any ambiguity. Like probably I would have said, okay, draw the circle inside the rectangle, but to the right side of the rectangle, right? Or similarly, I should have told you that draw two small rectangles on the left side of it. But I didn't tell you because I thought, because that was in my mind, that picture was already in my mind, and I was just telling you, okay, under the triangle or below the triangle, draw the rectangle, inside the rectangle, draw the circle. But my mind, it was there, but I could not express it. I could not tell you properly. So that is the reason why there is a communication gap. So the assumptions are basically the biggest barriers for communication, and it leads to a lot of misunderstandings. And assumptions, again, we cannot avoid those assumptions because based on our past experiences, based on our situation, we assume a lot of things. Only thing is we need to validate it. We need to ensure that whatever we are understanding is in tune with the sender's expectations, right? So this is why, again, George Bernard Shaw said, the single biggest problem in the communication is people think that it has already taken place. I thought I gave you full instructions and everybody should come up with the proper image, whatever is in my mind. But when I saw the results, it was not the same. And you thought you understood everything, very simple, straightforward. You understood whatever I told you. But at the end of the day, whatever you have drawn is not same as what I was thinking. Right. So that is the objective of this activity. And so this is a powerful tool to understand impact of our assumptions which are not validated. Right? The technique here we are using is basically experiential learning, right? Or activity-based learning. See, I can keep on telling you about assumptions, wrong assumptions, not validating assumptions and all. Everybody thinks that, yeah, I know about it. But then when we actually draw this, we understand that even in small activities like this, we keep assuming a lot of things and we don't validate it. So that is why it is a very powerful tool to learn the concepts by practically doing and understanding. And one more advantage is, as Madam said, every learner has a preference: auditory, visual, kinesthetic. So this involves all the three. I have shown you the diagram. I asked you to do this, and also I was explaining you the instructions. Right. So it involves all the three types of learning. Right. So as the activity-based learning is basically based on the principle of Benjamin Franklin. He says that tell me, I forget; teach me, I remember; and involve me and I learn. So now you all know, you all have, were involved in this activity. Now, okay, if I ask you again to draw the same thing, definitely you would ask me the questions, right? Okay, where should I draw? Right? So that kind of thing. I think somebody is
Yeah, Dr. Rajesh, I think you are annotating.
Yeah. Okay.
Yeah.
Okay. So now the advantage of this experiential learning is basically the active engagement of the participants. You all were drawing, right? And then more effectiveness than theory. And then let's focus on memorizing the topics. You don't need to really memorize a lot of things. And then there will be long-lasting impact, right? Because of this experiential learning. And disadvantages are basically needs more planning, right? Because I need to plan what kind of activities are suitable for this particular concept. And similarly, if I have to do the same thing in online versus offline, maybe the execution will be different, right? So I cannot make the same thing which is suitable for online, can make it suitable for classroom training. And then it needs relatively more time than traditional lecture method. Maybe I can tell you in 2 minutes what are the disadvantages of wrong assumptions, what are the advantages of validated assumptions. But here we are doing an activity, so it takes more time. And supervision is required because I need to do the instructions, give you the instructions. And it may be difficult to do this properly with differently abled people, because some people may not be good at visual or auditory kind of thing. Maybe there may be some problems. In terms of do's and don'ts, we need to plan the activity properly. And I would suggest that pilot the activity with small group, so that okay, whether people are able to understand what instructions are given, whether they're able to do the activity properly or not. And based on the feedback, you can fine tune your activity, and then be ready to handle the participants. This is very important. Why I am telling this is, like, say for example, if there is a participant who comes up with what exactly in my mind, then the fun will be lost. The surprising thing will be lost. So that is the reason why I said, if you have any clarifying questions, please send me direct message. Don't put it in the chat. Because the moment one person asks, okay, where should I draw the circle? Then everybody starts thinking in those lines, right? Then the entire, the element, surprise element and fun element will be missing. So that is the reason why we need to be able to handle all types of participants. And in terms of don'ts, don't do it with a larger group of participants. If you're having 50 or 100 people, it's very difficult, especially in the online session. And don't repeat the same activity with same set of participants, because again, the surprising element will be missing. And then don't rush the participants to complete it fast, especially as it is involving the activity based learning, and people have to draw the picture and all. Don't rush the participants to complete it fast. Give them time. Once they complete it, you can go for the next instruction. So those are some of the do's and don'ts. So thank you so much, and open to any feedback or any questions.
Thank you. Thank you. So you actually completed very quickly. But that's an interesting activity, I think, to demonstrate the communication gap that happens when we communicate in the best possible manner, but still it is not understood exactly. I think very well done. It was a very interesting way of explaining and role of assumptions and communication failure from both these sides. I think very well explained.
Thank you, Bharat.
So any questions about Mr. Vijay's presentation or the last session that we had? So if there are no questions, I'm posting the feedback form. Kindly give the feedback quickly so that we can close the session after the feedback. Yeah, great activity, I would say, great presentation. Thank you.
Thank you, Bharat.
I hope you are able to open the feedback form.
Yes, ma'am. Yes.
I've received 5 responses, waiting for all others to complete before we close the session. So our next session is going to be the last session, and it will be on disclosure of medical error. That's another common challenge we experience when it comes to talk about complications or even actual error that has happened in patient care. Those who have done can write done in the chat box so that I know who all have finished. If others are still doing, we will wait. Otherwise, we can close in case we are not doing it. Then I'll paste the form in the group also, I think, so that in case if you wish to submit later. You have pasted in the group also, in case if you have not done it now, you want to do it later. We can do it, you can submit after this session also. So I think with this, we come to the end of this session. Thank you so much. We are ending on time, not like other days when we closed almost like 10:30. So thank you so much, everyone. Thank you.
Thank you all. Good night.
Thank you.
Okay.